Well, good evening. Welcome to the 2021 Delaware Mini Medical School, jointly produced by the Delaware Academy of Medicine, Delaware Public Health Association, and ChristianaCare. We're delighted to have you all joining us in this virtual environment. I hope that your last year of COVID pandemic has not been too terribly distressing, although it certainly has been a challenge for all of us in medicine and in public health, and certainly you in the community. My name is Tim Gibbs, Executive Director, and let me click on the correct screen so I can actually advance. So about Mini Medical School, we're going to be meeting for 6 consecutive weeks. At the conclusion, if you've attended all of the classes, and you will be able to view these online afterwards recorded, you will be eligible to receive a certificate of attendance, which will be emailed to you upon request. That says mailed, it'll be emailed. There is no continuing medical education credit offered with this series. And attending Mini Medical School does not qualify you for any job, but it does look great on a college application. A little bit of housekeeping, there will be a presentation. Perhaps there will be a brief break. Perhaps not, but then there will be the presentation conclusion and Q&A. And what Dr. Bohner, our presenter for this evening, requests is that you go ahead and put your questions into the chat as she does her presentation, and she may very well respond to them on the fly. For Q&A, please try not to ask questions that are personal health questions, and do ask questions that are on topic for the presentation. There will be an evaluation after this. For all of you, we'll be sending an email with a link to a SurveyMonkey evaluation. Completing this form helps us in improving MiniMed and provides feedback to our faculty speakers. PowerPoint presentations and the videos will be posted to DelawareMinimed.org within a couple of days of the presentation. And at this point, I'm going to introduce this evening's speaker. And I need to just pull something over here. So Diane Bohner, MD, FACP, is the Medical Director for Patient and Family-Centered Care and Resource Management at ChristianaCare. She is also an attending physician in the Adult Medicine Office at the Wilmington Hospital Health Center. A graduate of Eastern Virginia Medical School, Dr. Bohner completed her residency in internal medicine at ChristianaCare in 1996 and has worked in the health system ever since. Previously, Dr. Bohner was medical director and physician advisor to the Department of Utilization Management. Currently, she serves as chair of the Utilization Review Committee. From 1977 till 2006, Dr. Bohner worked in private practice as an internal medicine specialist for the Lancaster Pike Medical Group. During this time, she participated in the Practicing Physician Education project sponsored by the American Geriatric Society and the John A. Hartford Foundation, a project that involved training physicians to present community workshops on geriatric issues. Dr. Bohner is especially interested in geriatrics and has given presentations on a wide range of topics related to gerontology. As a physician staff faculty member for ChristianaCare, Dr. Bohner has taught internal medicine residents through all phases of their training. Dr. Bohner's other responsibilities include teaching residents about ambulatory internal medicine and training them in the outpatient clinic. Dr. Bohner is also clinical instructor of medicine affiliated with the Jefferson Medical College of Thomas Jefferson University in Philadelphia, now called the Sidney Kimmel Medical College, I believe. ChristianaCare has awarded Dr. Bohner and her teammates numerous Focus on Excellent awards for her work in areas such as addressing the needs of long-stay patients, improving patient flow, and identifying patients who are at risk for readmission before discharge. And Dr. Bohner is a fellow of the American College of Physicians. Dr. Bohner, welcome. Normally we would do applause, and I'm not sure how many people we have here, but for you all online, almost 500 people registered for one session or another, and you might all be here. It would be thunderous applause, but Dr. Bohner, I will now turn it over to you. Thank you very much.
Okay, just give me a second. Thank you, Tim. Let me. All right, Tim, was that successful?
That was perfect. Thank you.
Excellent. That's always a good sign. So first of all, I'd like to thank you brave folks who have your videos on. When during the day and I'm working and I have meetings at ChristianaCare, a lot of times nobody will turn their video on and I feel like I'm talking to, I don't know, a wall or a computer, and I find that very difficult. First, I'd like to tell you a little bit about myself, and then I'll talk about where we hope to go with the presentation. As Tim said, I've been with ChristianaCare since 1996, which is a really long time, although it doesn't feel like that. The time goes really quickly. And one thing I was aware of as Tim was talking about my journey is that I really like to do new and different things. And so I was in primary care for about 10 years. I've always taught residents, and it was in that resident setting where I alongside of the residents would see patients come in that really, it was obvious that the traditional office medical setting for primary care wasn't meeting the needs of those patients. And I worked in that office for quite a long time, actually from when I graduated to maybe about 6 or 7 years ago. And really, that's when my love of working with people that were just super complicated in their life, that's when I found that passion, and that's what I love to do. And working at ChristianaCare has really afforded me to explore this area and to do new and different things. So we'll talk about that as we go along the way. I do encourage you, please put in questions. I can't see the questions, but Dr. Smith is going to help me out with that. And I'd love to answer questions as we go along the way. So these days, currently, I am working system-wide with what we call complex care, or the complex patient. And this is a relatively new coined term, although the patient or the person with these types of struggles is indeed not new at all. It's as if if you were reading through the medical literature, that this epiphany has occurred in parts of the medical community, but those of us who have been working in the struggle with this type of person have been well aware of it for a long time. So we're going to talk about the art and practice of complex care. All right, so we're going to do a little bit of the agenda. I'm going to talk about the definition. I'm going to talk about the components of complex care and the needs of people that we sort of label, although I don't like labeling people, but they're people who struggle with complex issues. What are the goals of complex care? And I have some stories, some patient stories, and some stories of some folks to talk about. And then we'll talk about how do we serve the population or these folks better. Now you'll see I'm going to really try not to use some of the terminology. In some ways it comes with its own language. Medicine comes with its own language, and working in complex patients come with its own language. So if I say something that's not really clear, please absolutely raise your hand, and I see there's one hand raised there already, or type in a message so we can clarify along the way. And Kimberly, you have your hand up. Do you have a question?
Kimberly, we're going to keep all our participants on mute just so that there's no extra talking. So if you have a question, go ahead and put it in the chat and I'll read it out to Dr. Bohner, okay?
Okay, so I won't have people talk about, they can't talk spontaneously. Okay. All right, so what is complex care? And what do I mean when I talk about complex care? And complex care has a definition, right? It's complex care is a person-centered approach to address the needs of people whose combinations of medical, behavioral health, and social challenges result in extreme patterns of healthcare utilization and cost. So let's go back, because I said I was going to be using some terms that may not be used every day, or that we might be using or see every day, but we're not really clear on the meaning. So we used the word person-centered. It used to be called patient-centered, but then we realized, right, people aren't always patients, but they are always people and they're always persons. And what does a person-centered care approach mean? And it means that we've sat down and we've involved somebody, a person and their family as part of the care team, as we create a relationship and learn what that person's goals with their lives are. Because the reality of it is that as a physician, my goal for you may be very different than what your goal is for you in your life. And if I just think you're going to do what I tell you to do because I think that should be your goal, then we're going to fail in taking care of people. So it's really about engaging with people and understanding their world and their desires and where they want to go with their healthcare and some other components of this. And this is really critical. I can't tell you how many times I used to, when I was in primary care practice, I used to have a woman who was a native from Korea, and she had diabetes, and her diabetic doctor, so high blood sugars, kept telling her not to eat rice, but there was no way in her diet that she was not going to eat rice. So she would make up her blood sugar numbers, and those were the numbers she would give to her doctor. And there was absolutely nothing therapeutic about that relationship because she didn't want to let him down. So she just made it up and lied to him. And so when we talk about person-centered, that's what I'm talking about. And then you'll see over in the corner or over on this side of the slide, we're talking medical conditions, and I'll talk about the medical conditions that we see that a lot of people have, and they are the same medical conditions that this group of people get that we're talking about. But unique to this population are more severe psychiatric illnesses, and we're not talking about sort of anxiety and depression. Lots of people have anxiety or depression or sadness at some point in their life. It's a natural part of lots of people's lives. We're talking about more severe mental illness, or we're talking about severe substance use. And we'll talk about what we see in the community these days. And then along with it, right, we have struggling social and environmental changes. And the phrase that we use here are the social determinants of health. And we'll get a little bit deeper into that as well. Okay. So we'll go to the next slide. So let's start. It's funny because part of this will show you what my view is on working with a population that struggles with all of these areas, is that we're going to talk about what factors impact health. So when I look at somebody and if I had to guess and say, what kind of factors in your world help to make you healthy or keep you from being healthy, there's different factors that play into that. And there's a pie chart, and it always surprises me because it's not what, as a physician, I would think were the major factors that play into your life. So when I was in training, right, it was all about clinical care, right? we can make people healthier just by delivering good clinical care. But when you look in this chart, and you'll see that clinical care really contributes about 20% to a person's health, which is really surprising if, like I said, when I was training, it was a physician-oriented or provider-oriented perspective, and we thought we could really make a big difference in people's lives. But in reality, there's lots of other things going on outside of the doctor's office that contributes to somebody's health. So you see, right, 30% here is health behaviors. And these are things like exercise and smoking and diet and, obesity, right? So there's health behaviors. 10% is the physical environment that somebody lives in. What is their home? What is their neighborhood situation? And then 40% are these socioeconomic factors. And it wasn't so long ago that healthcare really thought that it was not our responsibility to get into these social factors. Now, thankfully, that has changed. And you may say to me, you've seen these pie shapes before, and they may vary a little bit in percentages depending on where you look online and take a look at it. And I just picked one of them, but all of them sort of show this really the importance of the social health in people's overall health. So what are the social determinants of health? And again, if you went online and you typed it in, you'd see all different areas and definitions of it. But really what we're looking at is a constellation of these 6 areas. We call them domains, but these 6 areas. For somebody to be healthy, they need to have access to quality health care. And, we are one of the wealthiest nations in the world, and we have some really poor access to healthcare in areas. So for instance, if you are living in the city of Wilmington, and I don't know if you guys know, but where Wilmington Hospital is just off of 95, everything from Wilmington Hospital east towards the river, there's really poor access to healthcare. So anybody who's living in those areas cannot easily access healthcare. There's no urgent care centers, need to be able to have transportation, need to be able to figure out where they can go for their health, and they need to be able to address their health around hours in which they're working or going to school. But that is one of those areas that we call that is a healthcare desert. And it's really impressive. If you count the urgent care centers around from Wilmington Hospital east, if you want to go to an urgent care center, you have to go up onto Concord Pike to reach an urgent care health center. So if you look statistically, lots of people will say, oh, there's an urgent care center within 5 miles of everybody. They don't understand how 95 bisects the city of Wilmington and the steps that go into getting somebody from the city of Wilmington over to an urgent care. It really is quite dramatic and difficult. So let's talk about community and social contact. And this is the social supports. So with this is, do you have family? Do you have close friends around you who can help you and support you, right? Life has its ups and downs, and everybody struggles, but it's really that connectedness with other people, with our families, with our extended families, the people we choose to be a part of our families, our churches, our community centers. And when those relationships become fractured, it has a large impact on health. We talk about food quality and stability. I was talking about that area from Wilmington Hospital East. That is also a food desert. There are not, there's not food stores. There's little bodegas. They don't have fresh fruits and vegetables, but there's not really a food store until you get on Route 13, where there's a shop right down there. So we have food accessibilities in Delaware as well, which you think, you know, we're the wealthiest nation. We shouldn't have those deserts. Education, right? Everyone should have access to a good, solid education. There's certain things that when you graduate high school, you should be able to go to a safe high school. You should be able to learn certain things, particularly you should be able to read, do math. I mean, there's certain things you should be able to do, and you should be able to graduate high school. And we know that there are, depending on which high school you go to in the state of Delaware, that your experience can be dramatically different. And what you've learned when you've come out is completely different. And I can tell you, I work with a fair number of people that maybe drop out at 11th or 12th grade, but surprisingly, their reading level is not anywhere what you would expect a high school student level to be at. So it's access to education, but it's also the quality of that education as well.
Dr. Bohner, we have a question in the chat.
Okay.
And this is regarding access to healthcare. Why doesn't ChristianaCare open an urgent care center east of the hospital?
So you know what? That's a very good question. And I know that people have looked at those options. Christiana, well, I mean, I don't get to make those decisions. So that's one thing, but Christiana, right, is in partnership with, it just escapes me the name of the urgent care centers, and there isn't one. And there should be an urgent care. And then, it gets a little trickier because you get into some of those areas, and to put an urgent care or a medical facility in there, right? There's a lot of safety issues that arise with it, and it gets complicated. I'm not saying it shouldn't happen, because I totally think it should. But there's business thoughts that go into it as well.
Would that be Go Health?
Go Health. Yes, thank you. Sorry,
Yeah.
Go Health.
Someone in the chat put it in, so I'm glad they knew.
Thank you. Thank you. I love when people help me out like that. And then we're going to talk a little bit of economic stability, because I drilled down a little bit into economic stability in one of my slides to give you sort of some real life examples. And I used, when I talk about the city of Wilmington, I used the city of Wilmington in the area, thinking that a lot of folks on here might be from Newcastle County. But as I talk about deserts and places that really suffer from social economic issues, think about the city of Wilmington as I talked about it, then Newcastle as you come down the Route 9 corridor. So that has to do with immigration of folks from the city down into Newcastle. Those are really hard stricken areas. Also the Dover area, when you get down to Dover, and then Western Sussex County, you see a lot of the same thing. And there's definitely, I could talk about either one of those areas, like I'm going to talk about the city of Wilmington. And then of course we have neighborhoods and physical environments. If you ever, have had listened to some folks who have lived in the areas east of Wilmington, whether it be Southbridge, there's some different areas. That's, there's shootings, there's a lot of violence. I've had patients say to me, I can't really think about my health care because every night I have to put my children into the bathtub to keep them safe from the bullets that are outside my door, right? So it's the neighborhood and the physical environment and the safety and the presence of drugs and, perhaps an environment that's not really conducive to feeling safe and secure and being everything that you can be. Okay, so this is where I talked about the drill down, and it's very interesting. I just find it fascinating, the difference between if you look, a lot of the data will talk about Newcastle County as a whole for those social determinants of health that we just talked about. But you remember Newcastle County, right? So everything sort of from Middletown above has really, is really variable in the social vulnerability. So Newcastle County, right, has Greenville and Centerville, right, pockets where people have money and access to everything, right? We have all those private schools, right? They're not socially vulnerable, but there's areas that are very socially vulnerable, and they get averaged together when you look at Newcastle County as a whole. So if you look at the Newcastle County data, sometimes it doesn't look that bad. But in reality, when you drill down to particular areas, and I'm going to talk about census tracts, you can even see a disparity in the expected lifespan. And so I found this, and you have to dig really hard to find this information. So this is by census tract. And what do I mean by census tract? It has to do with the government, right? And when they come through and take the census, I don't know what the plural of census is, so census, and they delineate areas that are about, you know, they can vary in size, but they're small. So we're going to talk about one that's 0.6, and they put, and each one of them is numbered. And so they take the census and they can give you the public health data down to the square blocks that are in that census area. And so I pulled out one. So this is the, let me find my pointer here. So, right, so these are the census tracts. This is Wilmington, right? So this is the curve up here, the top of Delaware. This is the city of Wilmington. This over here is in New Jersey. So you see, right, there's some high social needs over here. And then I happened to drill down and I just picked one, right? And I actually thought I was going into the city of Wilmington, but I wasn't when I picked this triangle one here. And what I did was pull the data for this little triangle here, and it's only 0.6 square miles. And this is where 295 crosses Route 13, so just out of the city, but it's actually Newcastle, right near the Delaware Psychiatric Center. And it's, so it's just this little tiny area here, and I pulled the data for that. So it's over here and surrounded by areas that aren't quite as bad as it is, but this area struggles. And how do they struggle? I picked to drill down in the economics, because the reality of it is if you don't make enough money or you don't have enough money, then everything in life becomes difficult, right? That's the world we live in. And so for that tiny little triangled area, the per capita income, so per person income is $21,000, right? So I put it in, that's $1,767 a month, okay? The median household income is $52,000, but for this particular area, there are at least 3 people in a household, because as you can imagine, if you're making $1,700 a month, it's very difficult to pay rent, and we'll get into that. So here's 3.3. I don't know how you get 3.3 person, but that's averaged out in a household. And 13%. So, right, that's 1 in 6 people live below poverty. Now, what are we saying when you live below the poverty line? Which I think is set really low if you've ever tried to live on very little money. So I put what the poverty lines are here, right? For one person, if you are considered to be living in poverty, you're making $13,000 a year, right? So that's only, right, a little bit over $1,000 a month. So if you're making $1,200 a month, you're not considered to be living in poverty. And like I said, we're going to get into the causes of the cost of houses in Delaware, which is very high rent. and very difficult to live on these. So even if you're not considered to be living in poverty, there's a huge gap where you still make more money than being labeled with poverty that is very difficult to live in. So let's talk about rents. So I love it when my son always says to me, I have a 13-year-old son and I have a 15-year-old daughter. And it's my son who can't wait to get out and get his own apartment. And I don't, I don't think financially he might quite understands the cost of having an apartment, but we're talking about Newcastle County, right? And the fair market for a 2-bedroom apartment in Newcastle County is $1,000, right? $1,077. So if you were to have a minimum wage job, it would take, you'd have to work 2.9 jobs to be able to afford the rent and the rest of your life in Newcastle County. This is Newcastle County. So an affordable rent for a low income family, the poverty levels that we looked at, would be $603. So if you take a look at this, where we said in that little triangle, folks are making $1,700 a month. If you take away the rent, that leaves them $690 a month to do absolutely everything else. And $690 is not, it's a fair amount of money, but when you're paying bills, when you're paying for your car and your transportation and your gas and your clothing and your kids' school and your, the stuff that you need to go to work. Oh, and then there's food, right? You have to eat. You can see how these low incomes and these rents are too high to be able to survive on. Let me see if I put this in here. I did not. So what the estimate is that if you are in a position where you have to spend more than 50% of your income on rent, then you don't have enough money to make it through the rest of the month. And so we have a real crisis where we don't have enough affordable units for the incomes that we have in some of these areas. And then we wonder why people who can't afford everyday life things, why their health is so poor. And we'll get into that a little bit more. So let's switch over to medical conditions. And I always think this is, to me, this is the easiest part of that Venn diagram, right? Where we had social, medical, and psychiatric. The medical is actually pretty easy because the medical for these folks looks like the medical for everybody else, right? We see a lot of high blood pressure, right? And high blood pressure is with age or with genetics, right? Where your arteries get stiff and need to have medication to help bring that blood pressure down. And if not, you end up with difficulties such as having a stroke, right? Where part of your brain doesn't get enough blood to your brain, and you might lose, the most frequent one is one side of your body that doesn't have strength or movement, or heart disease. We have high blood sugar, right? So diabetes, which also leads to uncontrolled stroke, heart disease like heart attacks, and kidney disease. A lot of people will end up on dialysis. We see lung diseases like emphysema from smoking because we see high smoking rates. And in the areas that we talk about, folks have these diagnoses and these medical conditions, again, ubiquitous, right? We see it everywhere in the adult population, but they have the side effects and the consequences at an earlier age because they have reduced access to medical care, reduced access to healthy food, and they can't in their life make the adjustments to live healthier. So they get sicker sooner. They have heart attacks at the age of, ridiculous ages, 30, 35, dialysis, where they have to take your blood out and take all the toxins out because your kidneys don't work at very early ages. So although the medical conditions are the same, they are not as well controlled. So, and this is, I brought in, these are the causes of death for Newcastle County. And again, if you look at the city of Wilmington and Newcastle County, they look the same, right? Diseases of the heart. We have some cancers. Cerebrovascular disease is strokes. Accidents, diabetes is high blood sugar. But what it doesn't give you is the age and the complication rate. So you have to watch what you're actually looking at, because the age and the complication rates differ greatly. As I said before, or I alluded to before, the lifespan of folks who live in these impoverished areas is lower than folks who do not within the state of Delaware. Okay, so I have to make sure, because I could talk about this stuff forever. So this is Census Tract 156. So this is the same census tract. And this is the adjusted cancer rate. And this is, I wanted to show you this one too. So this is the same census tract as before, this little triangle that we were talking about, the socioeconomics to, where the surrounding areas, as you get out here, have fewer or have no significant difference in their rate of cancers. You can see that when we start to drill down in these census tracts, we do have different rates of cancer. And if there are significantly higher rates. If we looked at, some of this is an access to healthcare issue, right? So the things we do to catch cancer early are things like mammograms for breast cancer, are things like colonoscopies, right, for colon cancer, or pap smears, where we take some of the cervical cells in women for cervical cancer, and access to care and understanding of healthcare prevention varies greatly when you drill down to census tract. Okay. So behavioral health conditions. I assume there's no question, so I'm just going to keep going.
No questions. I will. Okay. I promise I'll stop you.
Okay. Like I said, I could talk about this forever.
Actually, there was a question that was answered in the chat, but maybe if you'd like to talk about it. Someone asked the darker colors on those maps represent higher social vulnerability. That was the question.
Correct. So and I didn't get into it because it gets into, there's a social vulnerability index that is a standard across the country that measures 12 areas of social needs and economic needs. And when they go through and they take all the census information, they calculate it for each one of these areas, and darker is worse. Okay, so behavioral health. So if you're lucky in your life, you will not have any up-close experience with what is called severe mental illness or severe persistent mental illness. And that's really the type of mental illness I'm talking about here. So I'm talking about schizophrenia, right? Which means break from reality. Right? It's a disruption in the way that the thinking goes in the brain. And so that the folks that have uncontrolled schizophrenia, their perception of reality, which is very real to them, it's not normal, right? If you took folks without this, the way that they perceived what was going on in the world and the way people interacted with them looks very different from the person with schizophrenia. And so schizophrenics generally are folks that hear voices and they're very real to them, and it may be more than one. And I can tell you, in all of the schizophrenics I've talked to, none of the voices are nice. They're demeaning voices. So they have to put up all day long with a voice telling them how horrible they are. For the most part, it's awful. Or they can see things that are really not there. Which, can you imagine, be really scary if you see things and you're paying attention, but other people aren't seeing it and you can't figure out what's real and what's not real. We're talking about bipolar disorder people, and these are folks that suffer from mania and depression swings, and that can vary. and mania, right? These are the folks that have all the energy, don't have to sleep at night, super productive, and they can get up at like 3 o'clock in the morning and clean their houses and all of that. So they're really moving really quickly and getting stuff done and spending lots of money, and they're online, and they have lots of boyfriends or girlfriends, and they're out. And then accompany a downswing and have a depression swing, where all of a sudden they can't move and they get out of bed. And so folks with severe bipolar, we see a lot of post-traumatic stress disorders, and right, and these are really dramatic, from severe childhood and from ongoing trauma. Now, I'm assuming that everybody on here is a high school student or older. And so I will share with you, when I first started really working with a patient group that was this type of patient, I would come out of the day and I would be super sad. These are folks that have been sexually and physically abused since the age of 3, 4, 5, 6, 7. I mean, things that nobody should ever have to put up with. And abandonment issues, and marginalization and racism. And so they carry these traumas with them, and they've had to figure out these coping mechanisms just to get through that part of their life. And then those coping mechanisms don't really function well in their current state. And so the consequences of uncontrolled serious mental illness, right? It stresses the families out, and what you see is a complete fracture in family, community, and workplace relationships. So I alluded a little bit earlier that the connectedness is really important to people's health, and they lose this because of uncontrolled psychiatric conditions. And if you are stuck in a place where you don't have access to healthcare, then it stays uncontrolled, and that just gets worse.
Dr. Bohner, you might not be the person to answer this question, but there are a couple questions in the chat asking if these types of behavioral disorders are something people are born with, or if they can develop them as they grow.
So I don't take care of kids, but frequently when they manifest themselves, they're not, and they manifest as teenagers or later, depending on which disorder that we're talking about. And you're not born with post-traumatic stress disorder, right? That is just a life experience. You can, there are young people with bipolar disorders that you have, but it depends on your environment that you're in as well, and how supportive you are. And schizophrenics, you generally see in their late teens and their early 20s is generally the earliest they break. But again, I'm not a pediatrician. I think all young kids should be healthy. But there are, I'm sure there's some folks that have these pediatric conditions, but they're not seen nearly as frequently as you see them in young adults and older folks.
And then real quick, speaking about environmental issues, there was a question about people who are hoarders. That seems to cut across the socioeconomic classes. Has anyone figured out a way to help them? Does ChristianaCare do anything with people who have that condition?
I work with a number of hoarders, and it is very, very difficult usually they're older folks that are hoarders, and we do have, you can, as a hoarder, be in therapy. A lot of these respond very well to therapy, but you want to have to participate in it. But hoarding is a very difficult behavior to address. And you have to get at the root cause of it. And then you have to start to unpack and have new coping skills moving forward.
And then we have a couple of follow-up, two follow-up. You started it. You said I could ask the questions.
That's okay. I'd rather just be interactive.
So we have question, what about narcissistic behavior? And then a second question, what's the likelihood that someone with SMI/SPMI know that they have these behavioral health issues, or does this differ based on the specific diagnosis?
Okay, so tell me what the first one was again.
The
No,
question
just-
was just
that one.
narcissistic behavior.
Oh, narcissistic behavior. Okay, so narcissism, and hopefully you guys get to have a psychiatric like presentation at some point. And I'm an internist by training. I should have told you that before. I am not a psychiatrist, but I do work with a lot of folks that have these issues. And narcissism is a personality disorder when it gets classified. And personality disorders, again, require a lot of therapy. And when I talk about therapy, we're talking about cognitive therapy, talk therapy, to really, right? People have different awarenesses of their level of illness, and they have to want to do the work to be able to change and learn behaviors to change those. Personality disorders, a lot of therapy, cognitive behavioral therapy. The SPMI and the SMI, so it can vary. I have had people that absolutely do not believe that they have a behavioral health issue and have had an extreme schizophrenia. I have a couple of those right now. And even in the face of consequences. So I'm thinking about a particular patient now who has been in the psychiatric facilities multiple times, has been injured, right, has been assaulted, all related to his behavioral health, but doesn't recognize at all that there's an issue. And part of our jobs as we work on with these people is to work with them. We use the phrase, we go to where the patient is. So if I'm working with Kate and she completely doesn't accept that she has a behavioral health problem, but she's willing to come see me because she has high blood pressure, I'm going to take that opportunity to develop a relationship with her and then to continue to have conversations to see if I can get her to start to understand that the other aspects of what's going on in her life. And maybe if she trusts me, she'll start to open up and she'll start to move along and be able to make some changes in her life. So they're completely variable. And there's absolutely people that know they're bipolar and want help for it. The same thing with schizophrenia. They'll come in, they'll say, you know, I've been diagnosed with schizophrenia and I really want help because this is not the way I want to live my life. People are at all places along the spectrum. You know, much like we're all at a different place along the spectrum of how much we should be exercising, right? So it's just like everything else and really is individualized as we work with people. Right? When you have an uncontrolled serious mental illness, it's very hard to keep employment. Then it leads to homelessness or near homelessness. When I say near homelessness, right? Homelessness, living on the street, going to a shelter at night. Near homelessness, couch surfing, staying with different people, living on their couches, living in a car. There's different ways you can be near homeless. But boy, they're so close to being homeless that we need to intervene soon. And they're targets for others, right? When you're on the street and you have a severe mental health, you're a target to be robbed, you're a target to be assaulted, to take advantage of. We see it all the time. And the way that your brain is working, right? You can't really navigate traditional medical systems for healthcare. I'll talk about it a little bit more. And you suffer from stigmatism and marginalization, right? Everybody's like, oh, can you see that person, right? See, they're crazy, or society gets them marginalized. So then they have that experience on top of it. Let's talk substances for a minute. Another topic we could go for like an hour on, but we're seeing, right? I see a ton of heroin use, right? In my whole life, I don't think I ever thought I'd be seeing as much heroin use, fentanyl use, and opioid use, right? So we see a lot of heroin smoked and injected. We see a lot of street or prescription opioids. And when I say that, I'm talking about like painkillers, right? Percocet, that sort of thing. Intentional and unintentional fentanyl. I don't know how many times I have to explain to somebody that if they're buying a drug on the street, it's as likely to not be the drug they think they're buying and that it has fentanyl in it. And this is one of the reasons it kills people. We see alcoholism. We've always had alcohol problems. And we see cocaine and marijuana. And quite truthfully, when I see cocaine and marijuana alone, I'm actually kind of happy because they're much easier to deal with than alcohol and the opioids. And what's the consequences of addiction? If you've ever had a person with we don't use the addiction, but substance use disorder in your family, right? You know, addiction's not fun. When you're addicted to something, you need to have that drug just to feel normal. You're not even trying to get high anymore. So these folks get up in the morning and the first thing they need to do is figure out what substance they need so that they can feel normal and face the world. There's theft, there's sexual exchange for drugs, right? We have no money, we have to find other ways to exchange. So very frequently you have folks with high-risk sexual activity. You have overdose, intentional and unintentional, and a lot of stigmatism, a lot of stigma, I don't think stigmatism is the right word, and marginalization with this population as well. All right, so I put a little bit in here because now I get into zip codes. You can't always get the data down, but this is, right, the reported prescription use in 8th graders in public school in Delaware. This is Newcastle County within the year 2016 to 2017. And the literature, if you read through it, will tell you that painkiller use in this group starts addiction. And actually a lot of it came from the use in the dentist's office. And then if you look, right, again, the darker, the higher the rate of use. And you see, this is the same area we were talking about before. And this is actually all of Newcastle here, right? So 3 to almost 5% of individuals 8th grade in public school have tried and used painkillers. So that to me is scary. This is a little bit about opioid related deaths. And here's the Delaware benchmark, and here's the actual result. Our opioid related deaths, again, fentanyl, heroin, Percocet, are off the charts. All right. And I think what that says to me is, you know what, we need a different way of talking about drug use and addressing it with individuals in a less marginalized way. And so we could totally talk about this forever. But when I'm talking to folks, it's, you know, if they don't want to quit, I don't end the conversation, right? I talk about how can we reduce the use. We have tips on how to use safely for individuals who aren't going to quit. But we are not doing a very good job with our opioid overdoses, deaths in Delaware. So what happens? So we call this the struggles, right? When you have a medical problem, you have a social problem, and you have a behavioral health problem, all of them different varying degrees, and some might be sort of stable and then they're not, and then they change. And with my teams, we call it the struggles, and we'll say, you know, they're just deep in the struggle. And how do you break the cycle of that struggle? And how do you break it, not just short term, but how do you break it in a long-term way? And that's what we try to do. And so you see this here. So this is my sort of circle here, right? If you have an uncontrolled psychiatric or substance use disorder and you don't get adequate treatment, and then your friends can't put up with you anymore and they abandon you, and then you lose your job because you can't hold down a job because you have an uncontrolled psychiatric disorder, then you can't pay for anything, right? You can't pay your bills, your medications, your car, healthy food. You're not being treated very nicely in the community, right? And you've got poor control of your medical conditions because you're not thinking straight. You can't access anything. You don't have any help from anybody, and you have no money. And then, right, when you get into this, you think I should just use again because my life is awful, right? It's easier to stay in this than it is to try to figure out how to get out. And so what my teams do is come in and say, right, how can we work with you in these different areas to try to disrupt this and give you a chance to get from drowning and underwater to above water, where you can start to sort of self-manage, right? Where you can take care of your own life and your own health. So what are the goals of complex care of working with these folks? And I would say the most important part is establishing a trusting relationship. The folks that have been in the struggles have been treated so poorly that they don't trust you. You know, people will say to me, well, he's paranoid, he must be a schizophrenic. And I'll say, well, we need to take a look at their life, because some of that paranoia may absolutely be reasonable based on that person's experience. And so how do we meet somebody and treat them with respect and have conversation and let them know that we're there with them and to help them through good decisions and bad decisions, right? Like, I wish I made good decisions all the time, but I don't, and neither does everybody. We have to understand the holistic life of the person. It's that whole person-centeredness. Understand the goals. What does that person want out of their life, right? So some people want to go back to work. Some people want to be able to get around their neighborhood and visit people. Everybody has a different goal in their life, but what is the person you're trying to work with? And we support self-management. How can we work with you to know how to negotiate the systems to get the care that you need? And if you're not able to self-manage, how can we put in long-term supports to help you, right? And you have to have a tremendous amount of patience, right? Tolerance, flexibility, and creativity. These are folks that don't show up to their appointments. They're folks that show up late to their appointments. There are folks that show up, right? And for a lot of reasons, whether it's transportation, whatever it is. They make bad decisions like the rest of us make bad decisions. And we have to be there to say, yeah, you know, that might not have been the decision that I would have made, but I'm not abandoning you because you made that decision. We're tremendously flexible, and I'll talk about that in the programs. And we get creative, right? Like, if we can't figure out a solution, like, how can we think of something new and out of the box that can support this person? What does this individual person need that will assist in their long-term stability?
So Dr. Bohner, there's a question in the chat. In establishing trust, shouldn't we take it where they are most comfortable? Would that be part of thinking outside the box?
Shouldn't we take what?
It said it. So
Okay.
Blythe, if you want to maybe ask more of your question. If you want to continue, Dr. Bohner, I'll butt in again once.
Okay.
Because
this is very important. You're right. And I might actually be able to answer that, right? We find that some people are more comfortable with a video visit, if we can arrange that, because they're in their own home, or they're comfortable with a in-home visit, or they're comfortable with having their best friend with them. And so the physical location and the mannerisms, some people may want a particular gender or particular race, and they control, right? They always have the right to say, I don't want to discuss that, right? So you say, you know, do you mind if we talk about your alcohol use? And if they say no, then there's a respect to that. And she can clarify or he or she can clarify in the chat box.
Yeah, she said establishing trust so they can open up more in talking about what they need.
Yep. And what we find is that, as you would imagine, they don't have one visit and open up and say everything, right? Because there's embarrassment, there's distrust, and there's a lot of complicated emotions that go into that. And so what you find is that as the relationship develops, the picture that one of my team members have, or the team has of the patient, changes because they start to feel safe and they open up more each time. And so everybody works at their own pace and has comfort in different areas. And you have to accept that people aren't always able to voice what's comfortable for them. And so we have to go the extra measure, right, to provide that comfort and that space and to recognize when we need to pull back or when we need to do something differently. And it's very important.
There is a question. What do you do if they don't want to talk about their medical condition?
then so you sort of become the, so it's a tricky line. So if I said, Dr. Smith, let's talk about your smoking. And I don't know that Dr. Smith smokes, so nobody take that away from this. And she says, you know what, now is not a good time. I say, and she says, I don't want to talk about smoking. And I say, okay, so can I tell you a little bit about my perspective on smoking in general? And she may say no, or she may say yes. She'll probably say yes, because nobody keeps saying no to their doctor for the most part. And then when I finish the conversation, I say, I'm probably going to revisit this every time you come back. So I want you to think about it. Right. So I get to turn on my mother hat a little bit of, you get to make your own decisions, but I'm going to push you a little bit. I'm not going to make you terribly uncomfortable, but I'm going to push you a little bit because we're going to come back to it. Now, am I going to push so much on smoking if she's using heroin? Probably not. I'm working on the heroin, right? You pick your battles. And you have to make sure, and this is, I think, true with everybody, when there are successes and people are resilient and they move forward, to make sure that you recognize and celebrate that, because this is a journey.
Okay, first of all, I'm neither using heroin nor do I smoke, and I've tried to talk my mother out of smoking my entire life. It's not going well.
Yeah.
But there is
you know what?
question.
And there's people who are never going to quit. And you're like, as long as you understand that these are the consequences of your actions,
Mm-hmm.
you get to do it, and I'm still going to be by your side. It's just like your mother, right? Like,
Right. And I will keep giving her grief for it, but she can.
Correct. I'm going to.
So there are two things in the chat. There is a huge issue with patients reaching out for care with the way they have been treated from past experiences in emergency rooms and outpatient offices. Not really a question, more of a comment. And then the question is, shouldn't we ask them about what they would like to talk about if they don't want to talk about,
Absolutely. Right. And that goes into, what is your priority? Right. I have my agenda. Now it's all in my head, right? Because Kate's using heroin, and that's high because I think she's going to overdose. So the heroin agenda is on mine. But you know what? I'm here to help her. So what's on her agenda? And her agenda may be, I want to be able to get back to work, right? And so there's a goal of, can we work on both of our agendas, right? Everything is a conversation and a compromise, right? I'm here to help you, but I'm also here as an expert in your health. And so I'm going to share my expertise with you. And you're absolutely right. And you're absolutely right about experiences in doctor's office and emergency rooms. That's people can have just horrific experiences with those. And it's very important when you talk about teams that work with these particular folks, that they are a certain type of person. It comes within them to work with this population, and they understand that everybody deserves respect, and they treat everybody with respect. And once people, and it's authentic, you can't make that up, right? These are authentic relationships you can't make up, where at the end of an hour that you just spent with somebody and gave them their undivided attention, they're going to hug you at the end of it because they've never been treated like that before. And then everybody's in tears. But you're right. You have to get over those past experiences of healthcare too, and you have to prove that you're going to be different. Okay. So story one, I have to watch the time. All right, so I said I could talk about this forever. So we finished that. I have 3 stories here, and then I have a little bit about what I've been so fortunate to do with Christiana. So I only might do 1 or 2 stories. No, I might only do 1 story, and we can come back to it, because I think you guys might be really interested in some of the ways we are changing how we do things to accommodate this population that before, people were like, well, you either function in the traditional setting or you go somewhere else. So Chris P, let's see, is a 60-year-old. He's not a make, he's a male. And he has complex medical, mental health, and substance use disorders, none of which are being treated like we talked about before. Or they might be treated a little bit, but not well. And the police bring him into the emergency room very frequently with confusion and alcohol intoxication. This is not an unusual story. I can tell you right now, I've got 5 people on my radar that come in constantly to the emergency room with alcohol intoxication, untreated medical problems that don't have help. He has high blood pressure, right? He's only 60. The older you get, 60 starts to seem young. So for all you young people out there, like, he's 60, he's old. I'm 55, 60, I'm like, he's young, right? His high blood pressure is not well controlled, and his drinking makes this worse, right? When he drinks, he doesn't take his medicines, he doesn't go to the doctors, and alcohol itself makes the blood pressure worse. He drinks really heavily throughout the day, and if he doesn't, he withdraws and he has seizures. So he has to drink now, and he can't hold down a job, right? He drinks to stop hearing the voices. I tell you, it doesn't work, but that's why he says he drinks. And they're hallucinations related to his schizophrenia. And on top of all of this, right, his voices, as I told you before, are demeaning, right? They tell you how bad you are. It's like, I can't imagine having a voice in my head every day telling me I'm a horrible person, right? I already have those feelings sometimes on my own. Everybody has them, but I don't need somebody telling me that all of the time. And these are actually a blend of patients. So actually, when I talk about this, this is a real patient, right? He's homeless and he's been assaulted in the shelter, right? Those are my folks that are living in tents. We have tent cities around Delaware where people gather and they live in tents outside because it's safer than going into the shelter system, right? So these are the patients. This is a typical patient, person that we would get. And we're like, oh my gosh, right? You look at this and you go, well, he drinks, right? He's been drinking for a long time. So he probably has liver problems associated with that and some other issues. He's got high blood pressure. He's going to have a stroke. He's going to have a heart attack. He's got untreated schizophrenia that's not really helping him out negotiate the world in any way. And that's making him feel worse about himself because the voices are awful. And he's homeless, so he has no place safe to go. He has no sanctuary, and he's been assaulted in the shelter system, and that's not unusual. You get assaulted in the shelter systems. All right. Oh, this guy's great too. This is a real guy. They're all real patients. They're all based on real patients. I'm gonna read this one and then I will go into what we've put together to work with these types of folks. So Mrs. J is a 55-year-old female with uncontrolled high blood sugars, right? Lots of people have diabetes. You see it everywhere. But hers are way out of control and nobody can figure out what's happening and why she doesn't take her medicines. And her blood pressure too. She can't figure out how to do that. And she gets admitted to the hospital with severe depression. Thank goodness she gets admitted to our psychiatric unit. She's not really just depression, right? So she has schizoaffective disorder. Talk about lucky. She hears voices that demean her and has the depression on top of it. So she has both together in a combination. And she had horrific trauma. I listened to it and thankfully I finally figured out what to say in response to these stories to say. So she was abandoned, physically and sexually assaulted, just treated horrifically. And I always think, and I get to the end of it and I think, yes, but look how resilient you are. Like, look at where you've made it to in your life. Well, it turns out what nobody recognized is that she can't read, right? So we kept giving her discharge instructions and we gave her doctor instructions and she can't read, right? She can fake it pretty well, but she can't read. She can't read the vials. She can't read medicine. She can't read any written instructions. And she lives in a low-income house where the low-income high-rises, drugs are everywhere. People come to your door, they have drugs. And she's 55 years old and she's smoking crack cocaine regularly, which doesn't help her schizophrenia and it doesn't help her blood pressure. But this is actually a real patient that we have worked with, and we have our ups and downs for a very long time now. All right. So what do we do? How do we do this better, right? My goal on this earth is to help people out. My passion is to work with these folks that I'm talking about, but it needs to be done differently to be successful. So we
This
have
might,
two.
this
Go ahead.
might be a really good time for me to ask this question because I feel like it will be answered in the next paragraph that you speak. How does your team make contact with these individuals? Are they referred to you afterwards for a follow-up appointment, or is your team somehow integrated into the normal intake process?
So that's very good. So let's start with, I'm going to start with the bottom one here, the Care VO Complex Care, which has been called things over the years, but it's been in existence for 8 years. And these are just these are wonderful community-based social workers. And I know this is a mini medical school, but I mean, there's other ways to care for people. Social work is one of them, and we'll talk about community health workers too. So there's multiple ways to get into the profession and to really do good work, right? So this team is social workers, and they go out into people's homes or meet them at McDonald's or meet them under the bridge, which is a big hangout place, to start to establish that relationship and to really work on the social economic piece, defining where they're at, what are their goals, how can we leverage and get them into a better financial and social state, and then hook them up with medical care. And you ask how these people come to us. So we use, it's no wrong door. Wow, I have no idea how red marks just showed up on there if you see them. We use a no wrong door. So they may come from our primary care doctors or our specialist, ChristianaCare. So they might refer them in. Part of my job is I look at complex patients in the hospital and in the emergency rooms. So I might find them, and even if they're in the hospital, they're trapped. And so I can have somebody call to their bedside or go visit with them and offer the service. If they're in the emergency room, I can take a look at them and see if we can either meet them there or go after them. I also have access to some data which will suggest to me that a person may be having the struggles, the complex set of them. Again, whole other talk. And I can read through the data and start to target people and get into their charts and see if they qualify for the program. And now, how do we go after them, right? So we want to do one of two things: have somebody who knows them, ask them if they want to participate, or we'll try to call them and we'll reach out, call them, leave a message. We will try to figure out if we know where they're staying. Are they staying at the Mission? Are they staying at where are they eating? Emmanuel dining room? Do they panhandle? Do they go to dialysis? They're trapped for 4 hours when they go to dialysis. You can find them there. So we start to play the sleuthing game of how to find them. And we'll do drive-bys, which is not a very good term because it sounds a little violent, but we'll go and knock on doors and we'll leave cards and messages, right? And our goal is to say, hey, listen, we haven't gone away, right? They get calls from lots of people, but we're still here. And sometimes they don't engage with us. If they don't engage with us, we'll be like, can I check on you in a month? Or if they totally don't want anything, we'll say, here's my phone number. And we have people call us back that way. There's some eligibility criteria, again, not getting into it, but I try really hard to work in the gray and try to serve as many people as possible. And you know what, if somebody's referred to us and we're not the right referral place, we don't just say no, we figure out the right referral place and help the person get there, right? You have to complete the cycle. You don't just say no and turn somebody out, right? You're like, that's not okay. We're the experts. We need to help you.
So quick question, is this program open to Pennsylvania residents with Pennsylvania Medicaid, only Delaware? You know, who's available?
Okay, so right now, this program is open to, so Christiana takes financial risk for patients. And it's open to Delaware Medicaid, where Christiana takes financial risk, some Medicare, and then some other commercial insurances. Won't get into it. So So it's one of those insurances. Delaware, Pennsylvania Medicaid is not in that, but we'll come back to that in a minute. Or we'll take a patient that has a ChristianaCare primary care doctor or family doctor, because we will not leave our own primary care doctors stranded alone to work with a patient that they don't have the support to do so. So we won't do that. We also will take any patient that's in the Hope Center, which is the Sheraton on 95 that was, I don't know, something else before that, that just opened up and houses homeless folks. And we also work with the Newcastle County Behavioral Health Unit that we work with. And again, if people call us, we will try to, if we can't serve them, figure out where to go.
And then 2 quick follow-up questions. What happens if someone refuses to accept your help? And at what point do you give up helping folks that rebuff all your efforts?
So what we do with them, we don't actually ever give up on them. I guess maybe if they're violent and we feel threatened and we can't work with them, but we've not really had that in the 8 years that this has been open. But what we'll do, we're sort of the irritating mothers, right? So I'll put you in what I call a monitoring program, where I'm not calling you, but every time you show up to the ED, I'm calling you then, and I'm going to say, hey, how are your decisions working for you? Right? Because what I'm waiting for is some change in their life that may inspire them to get help. Right? But they can still say no. And I'll be like, okay, I'll just call you the next time you show up again. Right? We don't ever give up on people. We just don't.
So there was one more, and then we're going to let you keep talking because this still has to do with those last questions.
Okay.
For folks with serious mental illness or serious substance use disorder or co-occurring issues and are homeless, how do you keep the connection with all those individuals? Are you aware of any programs that provide housing support to those who are seriously seeking help but do not have a safe or stable place to stay?
Oh, yeah, housing is a nightmare. The other thing I haven't talked about here is that we do not, in either one of these programs, do it alone. We're in constant relationship with all of the folks who are in the state programming throughout the state, and with the community-based organizations, the friendship houses, those folks, right? Because it takes all of us and our skill levels to do it. Housing is a nightmare. So it takes probably about 9 months to house somebody in Delaware, which means we're usually stuck about 9 months trying to support somebody in a different situation. And so we have to, that we cobble together piece by piece. We may support somebody who's in a shelter. We've supported people living in their car for 9 months through the winter. We will try to figure out and cobble something together while we go through the different avenues to try to find housing. But housing, I have to tell you, if we could make a difference in any way, it would be affordable and safe housing, because once you're safe in home, it's much easier to self-care. But we have to figure out, I can't tell you the number of people we've supported living in their vehicle that doesn't run, that's parked on somebody's property through the winters in Delaware, or in a tent. We've supported people in their tents as well. So then this is actually, I'm going to just move on. So this is the last thing. So the new piece is the Center for Hope and Healing. And the Center for Hope and Healing sort of came out of the complex care work we were doing in the community with social workers. We now have nurses in the community as well, to say, you know, we were driving ourselves crazy trying to take somebody who was suffering and struggling and then get them here for their primary care, their family doctor, and get them here for their psychiatry, and get them here for their therapy, and get them here for their housing, and get them here for their food banks, right? We were like, it was just too hard, and it took like 3 years. We wasn't efficient. So we went to the institution and said, listen, we want to develop the Center for Hope and Healing, which is what it ended up calling. And the Center for Hope and Healing is really cool. And it's only, gosh, it'll be 2 years in July that it'll be 2 years old. And in one setting, it is primary care doctor, right? So family doctor who loves working with this population, right? a psychiatric provider, nurse practitioner, loves working with these folks, right? The therapist, who's amazing. Everyone should have therapy with Cassandra. A social worker who knows the ins and outs and the complexities of all of the available resources, and a community health worker who's also a drug and alcohol counselor. And then we have supporting staff, 2 nurses and a case manager. We have supporting staff. And what we do with these folks when they come in is all of your things are now at one site, right? And well, we actually have 3 sites now, but they're all located together. They all talk together. They're all working to figure out how to support you in the best way possible. And so you might come in, and when people come to us, they may have therapy twice a week for a few weeks, and then they see the psychiatrist. They might not have any real medical problems, but they get a full physical, and they get all of their vaccinations while they're there. And a social worker meets with them, and then they disappear and they go away. But then we send Lewis, our community health worker, out after them to find them, because a lot of times they just get embarrassed because they relapsed, and bring them back in, and we follow up with people, and we will even go to an appointment with them. We set up transportation. We just wrap around them, particularly when they first come in, and support them in every way. Now you can be in the program short term, 6 to 9 months, where you get stabilized and you go back to your own primary care doctor, or you go to another supportive environment that's not us, or you can stay with us long term in what we call complex care primary care. And we started that in the Wilmington Hospital to begin with. And it was really fun, right? But, you know, people don't show up, they show up late, but all the schedules are adjusted. They don't look like regular doctor's office schedules to accommodate crisis, to accommodate lateness, to accommodate walk-ins, right? Those are all okay. We will accommodate all of those, and we will not give up on you. We will not fire you from the practice unless you're violent. And we will figure out how to work with you. We will talk to you by telephone. We will talk to you by virtual visit. We'll help set you up with a virtual visit. We'll help you get a phone. We'll certainly see you face-to-face. We've seen face-to-face through the whole pandemic, except for the first 2 or 3 months. We then had a Wilmington hospital visit, Wilmington hospital site. Then we have a Riverside site up where, off of Miller Road, where the old, used to be a nursing home facility that ChristianaCare owned, but it's up by Home Depot that's up off of Miller Road. And then we just moved into the Hope Center. So we have 3 sites as well. We get crazy creative with meeting these folks and their needs. And the institution, where a normal primary care office might have 20 minutes to see a patient, the Center for Hope and Healing schedules on the hour. Again, it's to be able to accommodate phone calls and walk-ins and chaos and, you know, craziness. That goes on, where if you had a patient every 15 or 20 minutes, you don't have the capability to take them in without really stressing the system. And the care of these individuals, right, there's a lot of trauma to the teams that take care of these patients, right? Every day you're just watching such pain, that it requires self-care and team care around it as well. So we have to watch our teams, watch who might be getting a little burned out. We take turns when things get like really crisisy. It's a very particular team. They're very skilled at what they do. And they will step in when somebody taps out and says, I need to walk away for an hour. We're like, go walk away for an hour. Like, it's fine. So we can come back and be the best that we can do to work with these individuals. Okay. So that was actually, and I made it with 6 minutes to spare. There's my, I know, I'm totally psyched. There's my email. I think it's spelled right. If you have any questions, you know, I'm happy to answer by email. But we have 5 minutes, although I didn't let anybody take a break. I'm so sorry.
That's okay. If we had taken a break, you would have gone over.
I know.
You're good. All right. There are 3 questions in the chat.
Okay.
The Hope and Healing Center, do they provide family therapy sessions?
they do to the people that are in it. You can't come into the Center for Hope and Healing and just receive part of the Center for Hope and Healing, right? If you just need family therapy, you just go to Mid-Atlantic. I mean, lots of people do that. But Cassandra can do couples and she'll do some family sessions as well. And each one of these teams, I didn't tell you. So if one family member qualifies for the team, then we'll take on other family members as well, because you can't treat one person and have the others remain unhealthy. The dynamic doesn't work that way. And so we will work with families or spouse, however somebody defines family, to lift them up as a unit.
And then where is the Hope Center?
Okay, so the Hope Center is not the Center for Hope and Healing. We named ours first. The Center for Hope and Healing is those three places. The Hope Center is on 95 off of 141. And it is the old, for those of you that keep up with the whole history, the Capano built hotel that wasn't built to specs and then got sold once and then was sold to the Sheraton. It's in the worst place ever for a hotel. I don't even know how that happened, but it went up to auction last year in October, and the county bought it, and Friendship House with the county runs it, and it is transitional housing like other shelters, but it is, you can stay there, you get 3 meals a day. You have to stay in your room. I mean, it's not a party there, but it particularly caters to families, brings families in. And so it's new, and you can go look on the county site under the Hope Center or Friendship House, because the teams are doing really remarkable work there.
How do you care for people who might be violent?
Yeah. So we've only had one patient that's been violent, not in the community. If they're violent in the community, we don't meet them in the community. I can't put staff at risk, but we can meet them in safer situations. But there's a difference between somebody we treated somebody who could easily have gotten violent, but we sort of figured a way. First of all, we've all been trained in what to do in violent situations, right? They're all trained, not that we ever want to use it. We'll see them only at the Wilmington Hospital setting because we have access to constables. And you don't see them alone. There'll be multiple of us together. And this one gentleman, I swear that we've had one, we figured out that if we give people snacks too, we feed them and we give them drinks because, you know, they traveled and they don't have access. And so we provide snacks. And if we gave him a granola bar in each hand and let him walk around, he was able to diffuse his own anger. And in fact, we had the constables called a couple of times, but we left them outside because we thought they would make it worse. But if they're really violent, then I get on the phone with the behavioral health, Newcastle County Behavioral Health. And there are other ways to bring somebody into behavioral health treatment, whether willingly or against their will. And we'll reach out and start have conversations with the folks who can do it against people's will, to bring them in and give them the opportunity to be treated. It's not fun, but there are other options.
That's amazing, and you do excellent work. Unfortunately, there are some more questions in the chat, but since we're at time, I'm going to say if your question did not get answered, please feel free to reach out to Dr. Bohner at the email that's on the screen right now.
Yep, that would be great.
And then
that
Dr.
was
Bohner,
awesome.
Yeah, if you want to stop screen sharing, I think Tim has the website up for something. The Hope Center, maybe? I don't know.
Did I do that? Did I stop sharing?
You didn't, but that's okay. You can do it. Now you've done it.
Excellent.
Now you've gone and done it. All righty. Okay, hopefully everybody sees the Delaware Mini Medical School website. Dr. Bohner, thank you so much. Folks, this is where here we have the session today, and below this there will be the PowerPoint, and there will also be, once we compile it, the video from this evening's session. Next week, timely as always, we're going to have Tim Bowers giving a COVID-19 update, and that truly will be the most up-to-date information that's come from the CDC and the National Institutes of Health and so on. So we will see you all next week. Thank you very much. Have a great week. Take care.